Today, the topic for presentation is Fever with Rash in an Adult, the 10-Step Approach by Mic Drop Medics. So let's start with a clinical case scenario. Imagine it's 7 p.m. on a Tuesday. You're finishing up your shift when a 24-year-old grad student walks into the clinic. He looks a bit tired. He tells you he has a mild headache and a low-grade fever, about 38 degrees centigrade. He points to his ankle and says, "I think I have a heat rash or maybe a few bug bites from my hike yesterday." You look down. You see 3 tiny, non-blanching red spots, petechiae, no bigger than the head of a pin. He is alert and his vitals are stable. You might be tempted to give him some fluids, an antipyretic, and send him home. Fast forward to 3 a.m. That same student is in the ICU. Those 3 tiny spots have coalesced into massive purple lakes of purpura fulminans. He is in septic shock. His kidneys are failing. The transition from walking well to critically ill didn't take him days, it took him 8 hours. So what I'm trying to say is that in adults, fever with rash is often a medical emergency until proven otherwise. It's a clinical challenge where the skin tells you a story that the internal organs are often trying to hide. Our goal today isn't just to memorize the textbook list of 50 differentials, but to develop a rhythmic approach to catch the killer before the lab results even hit our desks. So here is a 10-step approach. When a patient walks in with a fever and a rash, before you look at the patterns or count spots, you need to ask one question. Is the patient unstable? If you see hypotension, altered mental status, signs of shock, or a stiff neck, you have already hit the red line. You aren't evaluating anymore. We are in a medical emergency. Think meningoleukemia, toxic shock syndrome, Rocky Mountain spotted fever, or dengue hemorrhagic fever. You need to pull blood cultures, but don't wait for the labs to come back. Start empirical antibiotics and prep the ICU. If the patient is stable, great. Now you have the luxury of time and can proceed with your diagnostic evaluation. So the rule is, if the patient is toxic, treat the shock before you start naming the spot. Once you have confirmed that the patient is stable, it's time to play the historian. You need to pin the rash to a timeline. If the rash appeared before fever, think internal trigger. This usually ain't an infection. You're looking at drugs or lupus. If the rash appeared with fever, this is a red flag for systemic invasion. The bacteria or virus have already entered the bloodstream. Think meningococcemia, secondary syphilis, or disseminated gonococci. If the rash appeared after fever, this is the classic viral signature where the fever burns and as it peaks or breaks, the rash makes its grand entrance. So in step 2, the calendar is your best diagnostic tool. Now in step 3, you get hands-on, where your thumb or a glass slide is faster than any lab test. So don't just look, start pressing. If you press the rash and it disappears, that's the blanching or the fade away rash. This means that blood is still in the pipes and is tucked away in the capillaries. We call this the vasodilatory lesions, likely viral or inflammatory, where the blood vessels are still intact. So this is your supportive care zone and it gives you a moment to breathe. On the flip side, if you press the rash and it does not disappear, that's the non-blanching or the fixed rash. This is called extravasation. The blood has already left the building and is leaking into the dermis. This ain't just a rash but a vascular leak. So this is your worry and workup zone and the clock has officially started ticking. Here we are hunting for meningococcemia, DIC or vasculitis. Another rule to live by is that blanching is a snapshot, not a permanent state. A patient can walk in with a blanching viral exanthem that can evolve into a non-blanching purpura as the patient crashes into DIC. So the rule is, don't just press, press early and press often. Next, step 4 is to look at the morphology of the rash, which is like reading the landscape. As a clinician, you aren't just looking at a rash, but you're looking at how the skin is being remodeled. We divide this into primary, secondary, and vascular lesions. Primary lesions are the initial physical changes in the skin caused directly by a disease process. They are defined by the size, elevation, and whether they contain fluid. So now let's have a look at the primary lesions. If it's flat and less than 1 cm in size, that's a macule, likely early measles or roseola. If it's bigger than 1 cm, it's a patch, think erythema marginatum in acute rheumatic fever. If you can feel it like a bump, it's likely a papule in secondary syphilis or a patch in erysipelas. Macule and papule are your bread and butter viral rashes. When they join forces, you get the classic maculopapular look of Zika, measles, and rubella. If the rash feels deep and firm, it's likely a nodule. Stop thinking viral, start thinking systemic, like erythema nodosum in TB, leprosy, and sarcoidosis. And if it's an itchy, transient swelling that's here now and gone in an hour, that's a will, the signature of urticaria. Now, when you see fluid, the size tells you the story. If it's tiny and has clear fluid, it's a vesicle, like the classic dewdrops on a rose petal in chickenpox, whereas if it's in clusters, that's herpes simplex. But watch out for the umbilicated vesicles, the vesicles with a central dimple. These are the calling card of mpox or molluscum contagiosum. If you see large blisters with clear fluid, it's a bulla, likely staphylococcal scalded skin or bullous impetigo. If they are filled with pus, we aren't looking at an infection but an immune system overdrive, like smallpox or disseminated gonococci. Next, we have the secondary lesions, which result from the evolution of the primary lesions, often due to external factors like scratching or infection or due to the natural process of healing. Secondary lesions are like looking for the cues of the past. If a blister pops and you see dried blood or pus, that's a crust. Think of the honey-colored crusts of impetigo. If a blister pops and there is epithelial loss, that's an erosion seen in toxic epidermal necrolysis. Whereas if it goes deeper into the dermis, it becomes an ulcer seen in anthrax. If you see a black necrotic crust like a cigarette burn, that's an eschar. In a febrile patient, the black spot is the tachynoir of scrub typhus. It's a diagnostic goldmine that most doctors miss because they don't look beyond the ears or in the skin folds. Next, we have the peeling of the skin. If it peels off in flakes, that's a scale, like toxic shock syndrome. But if it peels off in sheets, that's desquamation, a classic sign of Kawasaki or scarlet fever. If you see linear cracks into the dermis around the lips, that's a fissure, seen in Kawasaki, whereas the linear marks are the excoriation marks seen in scabies. Now moving on to the vascular lesions. This is the most critical row in the table. From the pinpricks of petechiae to the bruising in ecchymosis, this tells you that blood is leaking out of the vessels. Here on the extreme left hand side, we can see the classic rash of dengue, isles of white in a sea of red. Whereas on the extreme right hand side, we have the typical rash of Hinoch-Schönlein purpura, non-blanching palpable purpura involving lower extremities, especially the shins and the ankles. Next, if you see lacy nets of redness, that's livedo reticularis. Check for shock here because this ain't a rash anymore. It's a circulatory scream for help. So, in short, don't memorize the table, memorize the texture. Learn the language of the lesion, and the skin will tell you the diagnosis. We have looked at the timing and the texture. Now we look at the map. The address of the rash is more important than the rash itself. That's your step 5, the distribution pattern. Think of this as the compass points of infection. First, you have the cephalocaudal pattern. It's the head to toe flow. Think measles or rubella. Next, you have centrifugal versus centripetal. It's a tug of war. In centrifugal, it starts at the center and flies out to the limbs. That's your classic smallpox signature. Whereas in centripetal, it hugs your trunk and ignores the arms and legs. That's your chickenpox. If the rash is hiding in the flexural folds of the armpits and the groin, think scarlet fever. And the most famous one is the dermatomal pattern. If the rash stops perfectly at the midline and follows a single nerve path, you don't need any lab, that's a herpes zoster. So the thing is, you need to follow the map and it will lead you straight to the diagnosis. Step 6 is the diagnostic jackpot. In clinical practice, finding a rash on the palm and the soles is like finding a golden key, which narrows a massive list of possibilities to the 4 heavy hitters: secondary syphilis, Rocky Mountain spotted fever, hand foot mouth disease, and Kawasaki disease. So check the hands and save a life. In secondary syphilis, we look for the ham colored or the copper red spots with a BH collar and always ask for a history of painless sore. In Rocky Mountain spotted fever, the rash in the palms and soles start late, around day 5. So if you wait for the palmar rash to start treatment, you may be too late. Start doxycycline immediately if you suspect rickettsial infections. Next, hand foot mouth disease is the pediatric classic. Look for grayish, football shaped vesicles on a red base. Unlike other rashes, these often run parallel to the skin lines. If the patient also has painful mouth sores, you have found your answer. But in children, hand foot mouth disease is generally self limiting. But in adults who are symptomatic, you see that they experience nail shedding or onychomyiasis and significant peeling on the palms and soles several weeks after the initial infection. Lastly, you have the Kawasaki disease. This isn't just a rash, it's a systemic vasculitis. Look for the diffuse redness and swelling of the hands and feet. The classic sign is periangle desquamation, which is the peeling of the skin around the nails. And don't forget the crash and burn mnemonic, because fever more than 5 days along with 4 out of the 5 physical signs in the mnemonic, if met, is considered to be Kawasaki disease. Early treatment with IVIG is the standard protocol to prevent cardiac diseases here because there is a high risk of coronary artery aneurysms. But adults experience more intense joint pain and may have a higher incidence of hepatic involvement compared to children, though it is very rare. Now moving on to step 7. Here we look at the mucosa because it tells us the inside story of the rash. Let's decode the numbered diseases in adults. The first disease, measles or rubella. Unlike children, adults have a pretty severe presentation. Along with high fever, cough, coryza, and conjunctivitis, look for the Koplik spots on the cheek and watch out for black measles, panencephalitis, and deadly pneumonia. Second disease, we have the scarlet fever. Here we look for the strawberry tongue, sandpaper rash, and the Pestier's lines. In adults, it's not always a sore throat. Check for surgical site infections and rheumatic fever. Here you also need to rule out Kawasaki disease because it can also present with a strawberry tongue. Third is the rubella or the German measles, where you see Forsheimer spots on the soft palate and enlarged posterior auricular lymph nodes. Here 70% women have arthritis or arthralgia, and there is a high risk of congenital rubella syndrome in pregnancy, which generally presents with the classic triad of sensorineural hearing loss, patent ductus arteriosus, and cataracts. Next is the fifth disease, where kids get slapped and adults get gloves and socks, where we see painful purple swelling of the hands and feet along with symmetric polyarthritis that often mimic rheumatoid arthritis. In adults, if you see the sixth disease, they ain't just sick anymore, they are immunocompromised. You need to rule out another killer if you see palatal petechiae with a rash following amoxicillin use. That's infectious mononucleosis. This isn't just a simple drug allergy. So the rule is in fever with rash, the lips tell you if it's an emergency like Stevens-Johnson syndrome, which we are going to discuss. The tongue tells you if it's toxin mediated like scarlet fever or Kawasaki, and the palate tells you if it's viral like measles, rubella, and mononucleosis. Now, step 8 is the detective phase, where your history taking skills become a life saving tool. Here, you need to look at three main areas: exposure history, drug history, and the masqueraders. If your patient has been to a rural area recently, think scrub typhus. Any mosquito bites, think dengue, chikungunya. A new sexual partner, put secondary syphilis back on the table. But the most dangerous clues lie in the medicine cabinet. We have to rule out the heavy hitters like Stevens-Johnson syndrome and Dress syndrome. If your patient was started on any new medication in the last few weeks, you need to check for the scalp drugs like sulfonamides, carbamazepine, allopurinol, lamotrigine, and phenytoin. So, if the drug was started 2 to 8 weeks ago, it's most likely Dress syndrome, where you see generalized erythema which may progress to exfoliative dermatitis. Whereas, if it was started 1 to 3 weeks back, it's most likely Stevens-Johnson syndrome, where you see painful purple macules or targetoid lesions with severe mucosal involvement. Here, pain out of proportion to the rash is a major diagnostic clue. So what we do here is that we perform a Nikolsky sign, where we apply gentle tangential pressure on the skin with your thumb. If you see that the epidermis is peeling off like a wet tissue paper, you have reached a point of no return. Classify the damage based on body surface area. Under 10%, that's Stevens-Johnson syndrome, and over 30%, that's toxic epidermal necrolysis, where mortality rate hits a terrifying 50%. So the rule is, if you see fever with rash along with mucosal lesions after starting a new drug, it's Stevens-Johnson's until proven otherwise. Stop all drugs, start fluids, and call the burn unit. Now let's discuss the masqueraders. These are the immune-mediated diseases that hide behind a curtain of non-specific symptoms that do not get better on ceftriaxone. Acute presentations of SLE and dermatomyositis are often mistaken for drug allergy or a viral rash due to their low-grade fever pattern. Look for the malar rash sparing the nasolabial folds in SLE, whereas in dermatomyositis, look for the heliotrope rash and the Gottron papules over the knuckles. That is often a sign of paraneoplastic syndrome in adults. In adult onset still disease, look for the salmon pink rash. It is evanescent with the quotidian fever spikes. If you don't catch it during the spike, you will miss the diagnosis. So the unmasking clue is ferritin over 1000. In your post-transplant patients, a rash on the palms and soles with fever isn't always syphilis. It's often the donor cells attacking the host. So in step 9, we look for the systemic clues. If your patient feels like his bones are breaking, that's probably dengue or chikungunya, swollen glands, rubella or acute HIV, hepatosplenomegaly, you have likely entered the world of EBV or CMV. But never forget step 1. If your patient's BP is crashing, that's likely toxic shock syndrome. Now step 10 is the ultimate lab verdict, where you finally bring in all the evidence. Start with the basics like CBC, CRP and blood cultures, then move to the targeted tests. If you suspect dengue, order NS1 antigen. If you suspect the great imitator, run an RPR or VDRL. If the clinical picture is still a mystery and the patient is stable, a skin biopsy is the gold standard to rule out vasculitis. So now bringing everything back together, the first and foremost thing you need to do when a patient walks in with a fever and a rash is find out if the patient is stable or unstable. Then in step 2, find out the temporal relationship of the rash with fever. Then step 3, find out if the rash is blanching or non-blanching. Then look for the rash morphology and distribution. Step 6, you need to find out if the rash is also in the palms and soles. Then look at the mucosa and find out what is the epidemiology of the fever and the rash. Then step 9 is to look for the associated systemic clues. And step 10 is the laboratory confirmation and then go for treatment. So the next time it's 7 p.m. on a Tuesday and you see those 3 tiny spots, remember our grad student, don't wait for the purple lakes to form. Act on the petechiae today so that you don't have to fight the shock tomorrow. Thank you.